Hello, everybody. Good afternoon. My name is Garrett Schmidt. I am the managing editor for VBCExhibitHall.com. And I'd like to welcome you to today's webinar. It's hosted by Trella Health and Trella Health, and it is called 5 Key Components for Organizational Growth Within Value-Based Care. And I think there's going to be some really fun things shared here, and it's going to be a great presentation. So glad you joined. A few items of note before we get started. Some housekeeping items here. You are in listen only mode, so don't worry about muting your mic or anything. That's been done for you. You don't have to do that. We can't see you either, so don't worry. Also, we are going to have questions during the presentation, and we want to hear from you. So please submit your questions at any time. You don't have to wait for the Q&A session at the end. We will have a dedicated time for that, but you don't need to wait until then to submit your questions. So go ahead and put them in. There is a little module at the bottom of your control panel where you can submit the question. There's also a chat, but go ahead and put it into the questions area. And then we are also going to walk through some discussion items as well, and ask some questions to you guys also. Okay, and then finally, we are recording the session today, and so if someone is unable to attend for whatever reason, but they've registered, we're going to send out that recording to everybody, and so you'll get an email later on this afternoon that'll have a link to the recording, and then also the slides that you can download, and there's some additional material at the end in the appendix for your reference there. So without further ado, I want to turn it over now to our speakers today. We've got Mr. Joshua Price, who's the solution engineer at Trella Health. And we've got Arun Narayanan, who's the senior solution engineer, also with Trella Health. And we've got Mr. Jeremy Powell, who's the CEO of Acclivity. So welcome, gentlemen. And I believe Arun is going to get us kicked off. So welcome, Arun.
I'm going to go off video just to conserve some bandwidth. Okay, thank you, Garrett. And here's our agenda for today. First, we will describe what Trella Health and Acclivity do, and then dive into the Romeo method and cover some use cases. And then finally, we'll close this webinar with Q&A. Our mission at Trella Health is to empower meaningful change in healthcare. Through our solutions, we enable healthcare organizations to improve outcomes and reduce the cost of care. We are a qualified entity with CMS, and through this relationship, we have access to the chronic condition data warehouse and access to 100% of the Medicare Part A and Part B fee-for-service data. Our data science team has created thousands of metrics based on this data, and our Mosaic platform is an intuitive self-service analytics tool purpose-built for VBC organizations. Here is how Trella Health works with value-based organizations. We provide access to the market data to maximize business development time. With this data, our customers can evaluate their existing network partner performance. With our solutions, we help our customers identify those best performing physicians to add to their rosters, as well as provide very detailed competitive intelligence. We help our customers improve their referral patterns towards high quality, cost-effective providers. Now I will turn the presentation over to Jeremy to speak about Acclivity.
Thanks, Arun. Acclivity is a clinical intelligence company, and we partner specifically with Trella to take the network effect that's created by the Trella system and Mosaic being able to predict which cases or which partners might be most applicable to your value-based care network. Our system looks at about 10,000 different sources of data in real time across all 50 states, and today caring for about 7.8 million patients. And it allows for us to predict the patient cases that need the attention from those networked providers. And we're excited to chat with you all today and looking forward to lots of good questions.
Perfect. Thank you so much, Jeremy. So again, my name is Josh Price. I'm one of the solution engineers over at Trella Health here. And what I wanted to do today was take you through something we have now dubbed the Romeo method. So when Trella was founded, the goal was to become a leader in the post-acute healthcare space, and this was around 2015. And we did that by providing access to a national database of claims data and then using that data to identify excellent partners for organizations and agencies across the country. So in doing so, the clients we brought on board were able to give us valuable insight into how they used our platform to find new referral sources and then leverage their strengths to advertise themselves. So recently, by combining the directives of our customers with Trella's own internal knowledge, we came up with the Romeo method for evaluation. And the end result might be just a little bit different, but the goals are the same here. How do we use the tools that Trella and others like Trella offer to become leaders amongst the industry? Therefore, we created the Romeo method, which you'll see stands for research, organize, mobilize, evaluate, and optimize. So as we go through the presentation today, you'll see how each of these fits into the structure of Romeo, and also how we utilize a partnership between Acclivity and Trella to put this acronym into action. The first two will start with Trella, and I consider these sort of your preparation phases. Using market level data to identify a strategy based on your goals and ambitions. And that leads us into the mobilize and evaluate, which I sort of consider the action phases. This is where Jeremy will discuss the Acclivity product and how Acclivity can dig into patient level information to push change at the ground floor. And then lastly, Arun is going to hop back on to discuss the optimize phase, where we can identify where we hit the mark or didn't hit the mark, and then decide how we want to hone or refine our strategy as we move back into the research phase. Overall, I think most on this webinar would probably agree that you perform an analysis like this in some form or function today. However, the key benefit of the Romeo method is being able to visualize what step of the process we're in and start to become incredibly efficient at defining and implementing strategy. So that's going to take us to phase one. And in phase one of the cycle, it's crucial to investigate a few pieces of information. First, you need to be able to look at a data set that lets you evaluate the overall market, not just your own patients. How can we identify opportunity if we don't know where the gaps exist? It's great to be able to look at internal data and identify where you as an organization can do better. But to contrast that idea, how can you also take what you're good at and expand your services where they're needed most? As a value-based care organization, the benefit that you bring most is connection. You have a network of providers and facilities that can provide excellent and coordinated care. And there are beneficiaries across the country that right now don't have access to that type of service. And that's just one example of a gap that exists that we can't see in any other way except from a market perspective. Identifying opportunities in your current market or future market to serve the patient. So hand in hand with that is being able to define a strategy. I tell the story a lot of one of Trella's customers where they were the only home health agency in the county that had access to at-home ventilators. And they wanted to refine their strategy to focus on providers and patients that needed these services. That's a strategy that can have a lasting impact in the community. And those are key pieces we want to identify and target. And then lastly, identify the leaders. So let's say in the case of an ACO, this is finding physicians across the state or region that are providing great care and offering great value to your organization. We need to identify the leaders so we can do one of two things. Either find a way to bring them into our organization or take the knowledge they give us and understand where we can improve. So there's a couple ways that we can do that in Trella today. And I wanted to show one example. So this is a screenshot of our Mosaic tool, and our Mosaic tool is what's built out for value-based care organizations. And I wanted to show this to clarify how Trella and Mosaic can help make your research phase exceptionally easy. Now, this is just one example, but what this page is showing is a marketplace of physicians. And so what we do is use our national data set to create metrics at the physician group, facility, or ACO level to pinpoint leaders across the marketplace. We offer filters that allow you to hone in your particular market or future markets, and then stack rank these physicians based on the metrics you find valuable. For instance, it may be PMPY or it may be cost. It may be utilization or attribution. Maybe you want to target a specific chronic condition or a place of service, or even understand historical trends to visualize the future. The Explore page is where we can search for all that information and find specifically where we want to target. The other aspect of this page that you'll see on the left-hand side there is the network modeling. This can help us identify how a particular physician affects your roster, PMPY, total attribution, risk scores, so that you can immediately understand what value this provider can bring to your organization. Everyone has a different strategy, and that's what makes this tool so convenient. We don't want you to pigeonhole yourself into a particular approach. We want you to find what you are great at and expand those skills into your market. Okay, and that's going to take us to phase 2, organize. So in phase 2, you'll take the intel you gathered in the research phase and start to organize your tactical plan. Based on your market research and your company's goals, which physicians does it make sense for your team to target? Are there any operational adjustments you need to make to elevate your services and improve patient outcomes? This is your time to take the skills and knowledge you've identified and create a clear and competitive positioning statement. So I think kind of hand in hand, we also have to be able to identify what gaps exist. Are we trying to bring a strategy into a market that is already oversaturated? Or is there a real need for the services you provide? I think most in this virtual room would agree that claims data is just one part of the picture. It doesn't tell the story around the patient or the provider. It's certainly not Yelp or Google reviews, and it certainly doesn't tell us about the patient experience. However, the pitfalls of claims data also make it one of the most effective tools we have to look at care objectively. When looking at gaps, we need to identify if the need exists, but we also have to get more specific. Maybe the market is being served in a particular capacity, but the cost might be outrageous, or you have the ability to offer more care options. That's what claims data gives us the opportunity to assess. Gaps can be identified in multiple ways, and there is always an opportunity for improvement. And lastly, the big ticket item here is how exactly are you going to take that strategy into the market? Being the best at what you do is phenomenal, but now you have to make sure everyone knows it. What strategy or materials are you going to use to show the organizations around you why they should care? And so here's really another example from the Trella perspective as to how we can show that. So above, we're looking at a screenshot of downstream costs of what you'll see are 4 different inpatient facilities. So specifically, the screenshot that I've taken is looking at those inpatient facilities from the date of admission into the facility and for the following 3 months. What did the total patient spend look like? How did this facility help control the cost of care? So we have the ability to look at this in multiple different ways. We can identify this by looking at the entire patient population, but then we have the ability to get more specific. For instance, right now I've filtered this to only include patients that received a diagnosis that fell into the circulatory system category. And you can see there is a drastic difference in the cost of care for these facilities. On this page, I can also filter by specific episodes of care, or we can look at high acuity versus low acuity patients. And our goal here is really to identify a couple of different items. The first is, as an ACO or another value-based care network, should I be sending my patients all to one location? Or is there an opportunity to look at this data and manage these transitions of care in a different way by focusing on what facilities do well in specific areas and making sure those patients receive care at those facilities? To contrast that, if I'm looking at my own facility, how do I compare to the market? Should I be marketing myself as a leader in cardiac care, or maybe rehabilitation, or any other category? Data can be segmented and organized in a million different ways. We know that. But what we are trying to do is help you tell your story. You don't have to be the best at everything, but use data to your advantage and find where you do excel. Okay, so now I'm going to hand it over to Jeremy from Acclivity, who will take us through the next 2 phases of the Romeo cycle and shift our focus from identifying the strategy you want to enact from the market perspective and focus on implementing that plan.
Great, thank you, Josh. Yeah, it's exciting. If you think about sort of what we've set ourselves up for here, you are scouting for the team in sort of the R section, the research section. You've then got the team together and you're going to build a playbook about how to go approach the market. Now we're going to run some plays on the field, right? So the mobilize phase really allows for us to look at the individual patients and identify journeys that are most appropriate for them clinically and financially. So under value-based care, obviously you have some pay for performance, total cost of care, incentives, quality incentives, et cetera. And what we want to look at here is which of the patients are actually causing an impact on your particular approach that you've defined in strategy through research and organize, and how do we make sure that we provide the best possible impact for each patient in two very specific roles. So we'll think about a centralized role, as you guys know, a navigator role, a case management role, a coordinator role. Those typically look at the entirety of the population and can make decisions about referral journeys, about engagement opportunities, and that's taking action. The other kind of role would be a role very specific to point of care clinicians. So how do I inform a very specific at a glance document, as an example, to ensure that persons being treated at any point of care environment have clinical intelligence as part of what the solution provides to that particular end user. So I'll show you an example of that on the next chart. What we're looking at here is something called an at a glance document. This distills down the very most important features of the detail we have about these patients, garnered from 10,000 sources of data today, including real-time information from event notifications that are occurring across all of the organizations that are giving admission, discharge, transfer notices. It'll give us opportunities to react to transitional care management or annual wellness visits. It'll give us risk profiling. It'll tell us gaps in the coding for risk adjustments. It'll allow us to see functional status through the palliative performance scale estimates that are produced from data we gather. It'll allow for us to do referral journeys directly out of this kind of input. And it really ensures that we're aware of what services need to be provided based upon what behaviors these patients are taking across all A, B, and D. So one of the great sort of abilities for us is to look at that claims across all levels of care, marry it to all the electronic health record data, the HIE data, the event notification data, and really build a composite view of all things related to this particular patient at the point of care in any setting. And this really does set the stage for us to start measuring the things that matter in the next phase. So in the next phase, we're going to look at how do we evaluate how well these plans that we've first researched, which was the scouting, then organized, which was creating a playbook, now running the plays on the field, how well is all of that working as it relates to reporting the news? So the news is, how are we doing relative to our impact? How are we doing relative to the care delivery model? How are our patients achieving the best possible outcomes related to clinical or financial measures? How are we identifying the right level of approach? How are we measuring and scorecarding the things that matter as either leading indicators or key performance indicators? And how does that show up in the way that you would sort of identify opportunities for training or identify opportunities for sort of addressing a network approach that more fully aligns with what your strategy is? And so let's look at a couple of those examples. In this first chart, we're thinking about the specifics of how do my patients, according to my benchmarks, sort of how do they perform? And so we can look across a quarterly financial look back to allow for us to measure year over year, to measure quarter over quarter, and to look at how the specifics of the kind of care being delivered to these patients actually align to them specifically. So these are all identifiable patients under an attribution model or a membership model where we're specifically measuring the outputs of our service and those rendered services against the impact of the specific patients that we're caring for under either the attribution or membership model. So it allows us to have this financial lens to really always be able to do a check and balance of what have we done to get the right team on the field? How well are they running the plays we expected to execute? And what do we see as opportunities for us to improve? And where should we make those training or network adjustments for each individual organization or individual NPI level clinicians under those organizations? On the next chart, we'll look at things that matter relative to performance around RAF improvements, so risk adjustment factors. As we all know, Medicare Advantage and Medicare will specifically pay benchmarks based upon how much we are able to document the needs of a patient. So we want to look specifically at how we're doing relative to our typical risk adjustment factor. As you know, each of our aged adult patients will age each year and incrementally get sicker. So we want to make sure that we're measuring how well we've captured those HCC code opportunities, whether they're expiring or expired, or whether they're active and need to be recoded, and how much of that's being matriculated all the way down to the scoreboard about this population in general through time. And on the next chart, we'll look at what kinds of things are we doing to measure and manage things that are happening again in real time. These patients will have NDC level codes about them and their specific repeat medications that we can literally track how frequently they're filling, and then therefore ideally taking their medications as it relates to any of the conditions that are treated through repeat medication therapies. When we see gaps in care, we can actually create an engagement list where we see mismanaged medications. We can create an engagement list. When we see these things creating emergency department visits, we can create an engagement list. And again, these are patient specific and provider specific, all the way down to either the centralized staff to do navigation or engagement, or the point of care staff to recognize, hey, I've noticed that we're not taking the medicines related to hyperlipidemia or diabetes. What's going on? And those kinds of questions objectively lead to better outcomes, because you can ask a question about a specific med for a specific patient versus having to do a more generalized interview during your point of care engagement. And on the next chart, we'll specifically look at how well are we doing things related to patients that have had frequent or non-emergent or unplanned visits into any facility where there's an opportunity for us to pay attention to, care for, and then pick up revenue related to transitional care management. So this looks at the entire journey, not just the engagement that has to happen in that first 48 hours or the visit that needs to occur 7 or 14 days after that hospitalization. It actually looks at all the way through the billing so that we can recognize the payers themselves are actually adjudicating claims related to all the features of a transitional care management workflow. And these efforts will pay dividends both in clinical outcomes, but also under value-based care. Those things get tied to revenue and reimbursement. So we want to be able to measure how well we're doing even on the dollars and cents of these kinds of programs. And I think I'll turn it back to you guys for the optimize phase.
Thanks, Jeremy. This is Arun again. So the last phase of the cycle, phase five is optimize. So think of this as fine tuning. You've reviewed your network performance data. You know what your KPIs are. You've looked at the cost utilization metrics, patient outcomes, and then the downstream costs. And then you've identified those high performing, the top performers. Here is where you adjust your strategy. What is working, what is not working, and identify those opportunities for improvement. In the next slide, we show you how Mosaic can support phase 5. We have the ability to create custom networks of physicians and model those networks out. For example, we can surface the usual suspects of population health metrics like PMPM, PMPY, the HCC risk score for the attributed patient panel, readmission rate, as well as a variety of post-acute utilization metrics. Next slide. Yeah.
No, I was just going to add to this slide. This is really where you get the opportunity to look at how your overall network is operating and make any changes. So we showed you some other slides from the Trella Health perspective, and obviously Jeremy had quite a few things from his end as well, where you're going to get the opportunity, at least during this cycle, to really evaluate how your strategy is working. And so, specifically on this slide, we just have the ability to see what that utilization looks like, what the PMPM and the patient risk score looks like, and does it fit in with what you're trying to accomplish? We mentioned that there's many different strategies out there. This is not one size fits all. I was at a conference recently where we were able to, or one of the speakers mentioned that value can happen, or value is appropriate for providers of all stripes. And I think that really rings true. There's a lot of different ways to approach this. So yeah, I think now we're going to take it to a poll question. And just see, Garrett, I don't know how we're going to get that up, but.
Hey, sorry, I'm working on, let's see, let me get
That's
this
all right.
here.
And just to sort of summarize a lot of the things we saw earlier, you know, Romeo is a method that is really more of a cycle. It's continuous improvement. And so once you hit that final phase, that is not the end of the story. There's always room for improvement. And so, you know, that final phase really just leads you back into the first one. When you're trying to refine your strategy, that just gives you the opportunity to go back and do more research. And so really it's a cycle, and I think it's a great, I mentioned that this is probably something that is familiar to you all, but this puts some visualization and some real words around it so that you guys can, as you're doing this, just identify the places that you do well and the places that you want to target in the future as well.
Okay, we got the poll question up now. Sorry about that.
Thank you, Garrett. So our quick poll, would you like to be contacted regarding the Romeo method and how you can partner with Trella and Acclivity to optimize your network?
Okay, we'll just leave this up for another second here. All right, I'm gonna go ahead and close this one out. All right.
We good?
We're good.
Okay, we can go to Q&A.
Okay, very good. And I'm going to come back on for this one. And this is a great presentation, guys, and very, very informative. And we did have some questions that came in. So in no particular order, I'm going to go ahead and ask a couple of these. Again, if you do have a question at all, please go ahead and submit it. And if we don't have time to get yours today, then we'll definitely get back to you via email afterwards. So go ahead and submit those questions. First of all, and again, in no particular order, could you talk a little bit more about what differentiates Trella from the other data analytics providers in the market?
Sure, yeah. I'm happy to take that one, Arun. So here's the biggest thing that we find often differentiates Trella. A lot of times with data, I mentioned there's a million different ways to segment data and to look at it in different perspectives. And a lot of folks really want to get specific with the data that they're looking at. In that regard, a lot of different other data providers across the marketplace, you typically need at least to go back to them in some capacity for custom reporting and things like that. What we're trying to do, and the biggest difference that we're trying to provide is the opportunity to look at data and segment it and strategize around it in the ways that you want in a SaaS application. So that's where, and I don't think we mentioned this already, I mean, we have over 14,000 different metrics that we look at every day to try and identify where we can get really strategic with things. And those cover a breadth of different, I mentioned a lot of them already, but cost and utilization, alignment and attribution, place of service, I mean, really just a lot of different ways. And then we try and segment it so that you can get aggregate level views, but you can get pretty specific as well, all the way down to the provider. So that would probably be the biggest difference, I would say, between Trella and a lot of the different data providers on the marketplace. I'm not sure, Arun, if there was anything else you were thinking of as well, but I'll leave it there.
Our QE status makes us very unique as well.
What is the QE? Could you expand on the QE?
Yes, it's the qualified entity relationship, the innovators license that we have with CMS. So it's not very easy to attain, and it's taken some time to get that designation.
Yeah, I'm glad you brought that up. That's a really important point and something definitely to brag about. So very, very good. Kudos to you guys. Okay, second question is what do you think ACOs should prioritize most in regards to the Romeo model?
First thing I would say is you have to have a strategy. I think there's so many different ACOs across the nation today, and different types of ACOs too. We're seeing changes made to the direct contracting program.
Mhm.
We're seeing, the ending of the next gen ACOs as well. And so there's lots of opportunity out there. And right now, we see that, especially in the direct contracting program with a little bit of the land grab that's going on today. But I think the real way that you can differentiate yourself is with the strategy that you offer. So, we mentioned this a little bit, and so I guess I'd bring phase 2 into light in just looking at the different ways that you can find what you're good at or where your gaps are, and either strategize around that to bring that to your market, or strategize how you can improve on that. So that would probably be, one of my biggest ones. Jeremy or Arun, I didn't know if you guys had different opinions on what would be important.
No, I think there's a 1-2 punch. What you described, maybe the lead punch followed by how does the ACO, who's often arm's length from a lot of the decisions made sort of in the exam setting, how does the payer or the ACO or any value-based care risk holder, how do they start informing individual journeys? Because, if you look at it, understanding rising risk, understanding the patients that are the familiar faces that are in some of the most complex either settings of care or types of disease burdens, and then how to treat them can be parts of how your strategy informs itself through just watching what patient journeys happen in your market. It's differentiated as Josh described, the way the contracts are shifting and the land grab that's occurring at the macro market level. Healthcare is almost all the way down to the zip code, and certain environmental factors, certain cultural factors, even what they're doing with equity is promoting this opportunity for us to sort of get better at treating patients almost down to the zip code level. And I think that kind of surfaces itself in the data as well. And if you had that nice 1-2 punch of setting a good strategy, but then allowing yourself to adjust based upon what the culture of your community, the culture of your clinicians, the makeup of that zip code level population, those two things really drive great outcomes. And I think that's why this partnership works really well.
Yeah, great points, guys. Okay, next question. Could you remind us again the provider and patient data sources you use, and how frequently is it updated?
I can take that one. So our data is sourced directly from CMS, the Chronic Condition Data Warehouse, and it is updated quarterly. So our most recent data available is 2021 Q3, and we'll be getting the Q4 data in. And so then we'll have the complete calendar year 2021 available on our platform.
And then we augment for those journeys that are at the point of care and in that very specific sort of patient level detail. We augment that with weekly updates directly from Medicare under the data at the point of care capability. Our equivalent of the QE is High Trust for being in that program. And then we get data in real time for hospital notifications and emergency utilization. And so again, this combination of market knowledge that's updated quarterly and then individual patient journeys that can be updated either in real time or weekly are sort of this great 1-2 punch we've been talking about.
Great. Yeah, very good, very good. Okay, next question is, which of the 4 Romeo phases do provider clients seem to have the most struggle with?
Okay, so I'll say this, and I think it also kind of revolves around phase 2 a little bit here. Marketing is a huge component, right? So you can often identify what you're good at or what you're not good at. I think that's something that you can see in the data, but you can also see just in real life and in real time. The question is, how do you take what you know that you can offer and present it to, and this is from the Trella perspective, so I'm sure Jeremy has his own thoughts around it too, but you have to figure out how to market around that. Your strategy is only as good as the people who know it. And if nobody else knows it except for the folks in your organization, I think that's, that you're doing a disservice to your market because you have a service that they need. So I mentioned the at-home ventilators. I mean, I think, a lot, we see it more and more, but patients like to receive care at home. I think a hospital can be a scary place. I know it is for me. And so when we're talking about the services that we provide and the places where we can make a real impact, I think it's making sure that your market knows that it exists.
And I think again, back to the 1-2 punch, the same is true about point of care journeys, right? So if it's not simplified and understandable, then it's not going to be used in any way, shape, or form, either in that centralized or point of care workflow. And so I think what Josh described is, if you know it, but you can't describe it elegantly and simply to the market, they're going to miss it. And if the clinicians can't immediately see value in a workflow that's been very well sort of made efficient through lean strategies, almost every EMR has done lots of lean work to make it work as elegantly as it can in the workflow of the clinicians. So if you can't dovetail this knowledge directly into that very specific workflow, you're going to miss them there too.
Great point, guys. Okay, moving on. Next question is actually kind of a follow-on. It says, Jeremy mentioned high trust is important. How do you build high trust with your provider clients?
So often the high trust certification is really just a good seal of approval for all the data and security governance, et cetera. It's like HIPAA on steroids, and you have to literally meet daily, weekly, monthly, quarterly kind of objectives. The fact that when we're involved, everything that we take in as a data lives inside of FedRAMP, which is a federal regulation, HIPAA compliant cloud inside of Amazon Web Services, means that when we get engaged with Trella and with the partners, you kind of get high trust because of our affiliation. So data never leaves those very safe containers inside of the cloud, inside of Amazon Web Services. Any of the journeys where a patient might move from one locale to another locale, that doesn't allow data to leave. It just literally puts an index and a pointer to another place. So really, it's you're guilty by affiliation, or association. So as soon as you're involved with us and we're under a subcontractor BAA, you in essence get that extension to us, to your health plans, to the data they hold, to all the event notifications, to the data that it holds, to Medicare and all of the data it'll give us over the data at the point of care, and to any MA or commercial plans as well. And they like that detail because it really short circuits the amount of scrutiny they have to put on us as a subcontractor.
Very good. Next question is, what agencies or entities, guidelines, or care paths do you use to identify compliance with optimal operations?
From the Trella perspective, that's a really tough one, because oftentimes compliance isn't necessarily in the claims data. What I will say is this: in the metrics and in the data, we have the opportunity to see physicians and facilities that are providing a lot of care, or well, let's just say providing a lot of care, but maybe not providing it in the best way or with the most value. So I can't speak for compliance, but what I can say is there's ways that we can segment and look at this data where we can identify if better value care can be provided. We look at the number of claims being submitted, and we can look at the total cost of care and see where there's some gaps in particular things. So that's all I'd say to that. But I certainly appreciate the question.
Sure, didn't mean to put you on the spot with that one, guys. But actually, that is all the time we have for the questions today. If you do have one kind of last minute here while we're wrapping up, go ahead and submit it. Again, we will get back to you afterwards. And with that in mind, if you could go on to the next slide there for me, Josh. I wanted to encourage you as we are closing out here to stop by vbcexhibithall.com, and Trella Health has a virtual booth there. And this is a place where you can interact with their team. You can see what they're doing, and there's some more materials and stuff for you to download there. So a lot of great resources. Also at vbcexhibithall.com is where you'll be able to find the recording of this session in the library in posterity. So you can come in a few months even and find it in there. We'll be housing it in there along with a bunch of other webinars and great resources for you. So definitely come and visit the Trella Health booth. And then lastly, If you have any questions or want to reach out directly to any of our speakers today, this is their information. Again, when I send out the link, you'll be able to get the slides and you'll be able to see this here. But if you wanted to take a screenshot or jot it down, this is the best way to get a hold of them. Or if you wanted to reach out to me directly, I'm happy to facilitate an introduction or put you in touch with these individuals. But thank you all again so much for attending. Thank you, gentlemen, for the presentation. This was very informative, and I know I got a lot out of it. So I appreciate everybody's time. I know there's a lot vying for your attention these days. So thanks for joining us. Have a great afternoon.
Thank you.